Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. In this week's video, we're continuing with our ongoing series entitled Special Tests in the Chiropractic Examination of the Spine. And this program is approved by the Board of Chiropractic Examiners for 6 hours of Category A continuing education credits under the category of history taking and physical exam. So this is a Category A course that gives you credits towards your mandatory Category A course hours as required by the Board of Chiropractic Examiners. Now this is session 2, and just by way of review, remember that in this program we're limiting our discussion to just 2 conditions of the spine. If you think about all the myriad numerous conditions that can afflict the spine, well, in this course we're narrowing our focus down to just 2 conditions, the conditions of radiculopathy and the condition of myelopathy. And remember that radiculopathy refers to injury to a spinal nerve root, either single, multiple, unilateral, or bilateral. And myelopathy refers to injury of the spinal cord. And you can have conditions where radiculopathy and myelopathy coexist, except in the lumbar spine, because if you recall, the lumbar spine, the spinal cord ends at approximately the L1 level of L1 vertebral level. So below the L1 vertebral level, we have the cauda equina, and any injury or lesion affecting the cauda equina is an actual radiculopathy versus a myelopathy condition. So we don't have myelopathy in the lumbar spine, but we have myelopathy certainly in the cervical and thoracic spine, and we have radiculopathy in the cervical, thoracic, and lumbar spine. And in our last session, we went through several diagnostic criteria, including diagnostic imaging measurements of spinal canal ratios to assess for radiculopathy and myelopathy. Now, in today's session, we're going to continue our discussion of these 2 conditions, and we're going to begin to explore the physical examination of these 2 conditions. Now, recall that radiculopathy involves a lower motor neuron lesion, whereas myelopathy involves an upper motor neuron lesion. So, of course, in physical examination, these 2 conditions are going to present much differently. And in today's session, we're going to start to explore some of these differences as relates to reflexes as presented in the physical examination. So we're going to review some of the reflex arcs and the neuroanatomy of reflex arcs involved with both radiculopathy and myelopathy. And then we're going to go into the physical examination, specifically assessing the reflexes in the cervical, thoracic, and lumbar spines that would be pathognomonic for a conclusion of either radiculopathy or myelopathy. And we begin today's discussion in the physical examination by broaching the topic of reflexes. And I love the concepts involved with reflexes and reflex testing. And for those of you that are in personal injury work or other medical legal work, perhaps workers' compensation type of work or independent medical evaluation type of work, I love reflexes, and you should learn to love reflexes as well, because reflexes are really one of the very few, if not the only, it's one of the very few truly objective tests that we have. So when you go through reflex testing, both abnormal findings and normal findings tell you valuable information. So even in the presence of normal brisk +2 reflexes, that tells you that many structures have to be working correctly in order to produce a normal brisk reflex. So this is an extremely valuable nugget to retain in the forefront of your mind when you're assessing medical legal cases for allegations of myelopathy or allegations certainly of radiculopathy. Radiculopathy is one of the most common allegations in medical legal cases, either cervical or lumbar radiculopathy. And so reflex testing is truly one of the few objective test measurements and physical examination procedures that we have at our disposal. So with no further ado, let's get into today's discussion, which is session number 2 of our ongoing series, Special Tests in the Chiropractic Examination of the Spine.
Okay, well, so then what about radiculopathy? Now that we know the clinical presentation of myelopathy, what about radiculopathy? Okay, so radiculopathy has a different clinical presentation. Radiculopathy manifests as sensory and motor symptoms related to a specific dermatome and myotome respectively. And patients will describe a localized region of numbness, tingling, or other paresthesias. And paresthesia simply means some alteration of normal sensations, such as tingling, tickling, prickling, pricking, burning, numbness, etc. Those are all paresthesias. And in addition, radiculopathy patients will report neck pain, shoulder pain, and upper extremity pain, typically in a strict dermatomal distribution. Now, it's up to you, doctor, to figure out the dermatomal distribution, because I've never had a patient come in and tell me, Doc, I'm having pain in the C6 dermatome. They don't tell you that. And it might not classically appear to be the entirety of the dermatome as you've learned it to be from the dermatome charts, but it's up to you to identify the area of pain and associate that with the most applicable and the most closely related dermatome as possible. Now, in the case of a bona fide radiculopathy, patients may report improvement in symptoms when raising their affected arm up overhead, and this is known as Bocote's abduction sign or the relief abduction sign, and this is considered to be a normal finding for those patients who have bona fide radiculopathy. And they may discover this by accident. They discover one day that when they raise their arm up overhead, it gives them relief from their radiating pain that radiates from their neck into their upper extremity. And this is also a validity sign. Now, I don't know if you've ever seen a patient or an examinee demonstrate Bocote's sign, but I have, and I can remember a time very clearly one day when an examinee came through the front door of my chiropractic clinic, and he had his hand on top of his head. He walked in the clinic with his hand on top of his head. And I immediately recognized that as a Bocote's sign. I said, hey, you have a Bocote's sign. And he didn't know what a Bocote's sign was, but he had a positive Bocote's sign. And sure enough, turned out to be a bona fide cervical radiculopathy case. So these are the types of associated validity signs that you would expect to be normal in a person with a bona fide radiculopathy. Okay, so let's summarize. With radiculopathy, symptoms are localizable to specific dermatomes and myotomes, and with myelopathy, symptoms are more diffuse, especially the sensory symptoms, and symptoms can involve both the upper and the lower extremities with myelopathy. Okay, so this person comes in and they've got these symptoms. What are we going to do? Well, as I mentioned earlier, when it comes to the physical exam, both for radiculopathy and myelopathy, one of the most important test procedures that we're going to use involve our reflex testing. And there's a couple of different types of reflexes that we'll test, beginning with the deep tendon reflex testing. Now, I know all of you out there listening to this program, you know what deep tendon reflexes are. In fact, you've probably just today in your practice probably tested reflexes several times. I don't know how many, but let's just say several. And you've been doing reflex testing all throughout your career. We're going to go through a review of deep tendon reflex testing so it refreshes your memory as to what it is exactly that you're testing when you tap on a patellar tendon or when you tap on a bicep tendon. So we're going to refresh your memory, and then this is going to quicken your thinking to what it means, and this is for those of you that are involved with medical legal work, what it means in the situation when you have absolutely normal reflexes. What does that mean? Now, I like reflex testing because reflex testing for myelopathy and radiculopathy, it's one of the very few completely objective tests that we have. And if you think about it, many of the examination maneuvers that we do involve a large subjective component. And that's not necessarily a bad thing, but for those of us that do some medical legal work, and even with regular examinees, it's good to know that we have some exam maneuvers that are completely objective, meaning that they're not dependent upon the examinee and the examinee's motivation. So for that reason, I really like reflex testing, and I want to go through a review of the components of a reflex arc here in just a minute. Now, when it comes to radiculopathy, we're going to be testing for alterations of the deep tendon reflexes, and that will also give us some indication as to the possibility of the presence of myelopathy as well. So deep tendon reflexes have characteristic findings for radiculopathy, and they have characteristic findings for myelopathy. And then in addition, in cases of myelopathy, we're also going to employ some tests for the pathologic reflexes, and there's several different types of pathologic reflexes, and we'll go over those here as well. So let's talk about the reflexes. Let's talk about reflexes. By definition, a reflex is an involuntary and nearly instantaneous movement in response to a stimulus, and that makes sense. That's what happens when you tap a patellar tendon. There's an involuntary and nearly instantaneous movement, and that's what makes reflexes so valuable, is that they're involuntary. They're not based on the examinee's motivation. So let's think about, for example, the bicep tendon reflex. That qualifies as one of the deep tendon reflexes. So in each of the deep tendon reflexes, whether we're in the upper extremity or the lower extremity or even up into the head, with some of the reflexes involved with the cranial nerves, there's 6 components of a deep tendon reflex arc, and I want to go through each of these components one by one. So let's imagine that we're testing the biceps tendon reflex. The first component of the reflex, deep tendon reflex arc, is number 1, the stimulus. The stimulus. And in this case, considering the bicep tendon reflex, the stimulus involves a rapid stretch of either a muscle and or tendon, generally both. But we're trying to get a rapid stretch of a muscle, and sometimes we have to go through a tendon with our stimulus in order to achieve the rapid stretch of the muscle. So that's our stimulus. We perform a tap with our reflex hammer, the purpose of which is to produce a rapid stretch of a muscle. The second component of the deep tendon reflex arc are the receptors. Our receptors, whose job it is to detect this stimulus, this rapid stretch of the muscle or tendon. And these receptors, in the case of the deep tendon reflex arcs, these are called muscle spindles. muscle spindles, which are specialized dendritic endings. We could call them dendritic endings. They're actually not dendrites per se, which I'll explain a little bit more in a minute. But you can think of these as specialized dendritic endings that are located deep within the muscle belly, in this case of the bicep muscle. So we have our stimulus, which is the rapid stretch, and then we have our receptors, whose job it is to then detect that stimulus. The third component of the reflex arc is the sensory neuron. And the sensory neuron travels in the sensory nerve. Now, sensory nerves are peripheral nerves. They're not spinal nerve roots. They're they're peripheral nerves. So if we're talking about testing for cervical radiculopathy, and we're doing a biceps tendon reflex, these sensory neurons are traveling in the musculocutaneous nerve. Other sensory neurons for other reflexes travel in the radial nerve. In the lower extremity, they travel in the tibial nerve, and they travel in the femoral nerve, etc. But we have these sensory neurons that conducts the impulses from the receptor up this special dendritic ending, or also known as a peripheral process. That impulse is conducted from the receptor up the dendrite to the nerve cell body, the sensory neuron cell body. And we know that the sensory neuron cell body is located in the dorsal root ganglia, immediately adjacent to the spinal cord. And then this nerve cell body in the dorsal root ganglion sends an axon, which is not actually an axon, it's actually called a central process, but you can think of it as an axon. It sends its axon into the spinal cord, in through the dorsal root and into the dorsal horn. And the dorsal horn is somatotopically arranged such that sensory information coming in from the arm and the trunk is located more laterally. The dorsal horn is somatotopically arranged such that sensory information coming in from the dorsal root, somatic information is located more posteriorly, and visceral information is located more anteriorly. In this case, with regards to the bicep reflex, we're talking about somatic sensory information that comes in through the dorsal root to make a synapse in the dorsal horn of the spinal cord. Then we see the fourth component of the deep tendon reflex arc, which is the spinal cord itself. And in the spinal cord, there is then a synapse from the sensory neuron, either directly monosynaptically to a motor neuron or polysynaptically through one or more interneurons, to synapse with the fifth component of the reflex arc, which is the motor neuron. Now the motor neuron then sends its axon out the ventral root, and the motor neuron carries the impulse back to the effector, which is the sixth component of the reflex arc, the effector. Now the motor neuron makes a synapse at the effector, which in this case is the biceps muscle. This synapse has a special name. We call it a neuromuscular junction. Now, all the muscle cells that are innervated by a single motor neuron, those are known as a motor unit. And here the motor neuron releases neurotransmitter chemicals. We know those as acetylcholine. They're released from the motor neuron, travel across the motor neuron junction, neuromuscular junction, and interact with the effector, which in this case is the bicep muscle, causing a depolarization of the membrane of the muscle cell, Excuse me there, had a phone call coming in. So it's the effector, which in this case is the bicep muscle, that then carries out the response. So what is the response of this whole deep tendon reflex arc? Well, it's a contraction. It's a muscle contraction. We know it as the knee jerk or the biceps tendon jerk or the reflex jump. It's the contraction of the muscle. That tells us that indeed this circuit, this loop, this arc is functioning. So for those of you that have your notes and those of you that are watching the PowerPoint presentation, I have a diagram here of the reflex arc, this time related to the patellar reflex or the knee jerk reflex, and it shows each of these components of the reflex arc. So let's go through this. The stimulus involves a rapid stretch of the muscle. The stimulus is applied by the reflex hammer coming down on the patellar tendon. So therefore, the stroke depth and rate at which you tap that tendon is important. It has to be sufficient to cause a significant stretch in the muscle. For that reason, it's important to have a couple of different sizes of reflex hammers, because for some very large individuals who perhaps have a lot of tissue around their knee, a small standard reflex hammer might not be heavy enough to impart a significant stretch on the quadricep muscle. So assuming that your reflex hammer is adequate, the stimulus is picked up by a stretch receptor. We said that these were muscle spindles, which are specialized receptor endings on the end of these sensory neurons. Now, these sensory neurons that we find in the peripheral nervous system are classified as pseudo-unipolar neurons. So we don't call these dendritic endings. We call these peripheral processes because this process emanates from the nerve cell body, which is located in the dorsal root ganglion, out into the periphery. We call that a peripheral process. And therefore, the muscle spindle is simply a specialized receptor ending at the end of this peripheral process. So the peripheral process picks up this rapid stretch of a muscle, which is the quadricep muscle, and it depolarizes, and it sends an action potential up this peripheral process to the nerve cell body at the dorsal root ganglion, and then continuing on now through the central process up into the dorsal horn of the spinal cord. There, a monosynaptic synapse takes place with the associated motor neuron, and the motor neuron then through its axon goes back to innervate the quadricep muscle. And all the muscle cells that are innervated by this one particular motor neuron are known as a motor unit. And in the quadriceps we have large motor units where one neuron can innervate hundreds or even thousands of muscle fibers. Then down at the neuromuscular junction, release of neurotransmitter chemicals, which we call acetylcholine here in the peripheral nervous system, causes a reaction, and we can just summarize the muscle contraction sequence of events as a reaction. We don't need to go into every step involved with excitation, contraction, coupling, and calcium release and all of that stuff, but we know that there's some change that takes place in the muscle that causes the muscle to contract, and that's a normal finding in the case of normal reflexes. And just one more thing that I want to point out, and for those of you that have the PowerPoint presentation, you can follow my mouse pointer here. Well, we notice that the sensory neurons are coming up and entering the dorsal root, entering the spinal cord at the dorsal horn of the spinal cord, and then the motor neurons leave the spinal cord by way of the ventral root. Well, when the dorsal and ventral roots join, that becomes the spinal nerve root. Well, these neurons, both sensory and motor, then continue to migrate toward the periphery. And as they get into the periphery, they start to travel in the named peripheral nerves, both in the upper and lower extremity. So if we were talking about the biceps reflex, these sensory neurons travel up into, join the spinal nerve root by way of the musculocutaneous nerve. These motor neurons travel away from the spinal nerve root down to the quadriceps. No, in the biceps, if we're talking about the biceps, that would travel in the musculocutaneous nerve. With regards to the patellar reflex, these neurons are traveling in the femoral nerve. Okay, so I mentioned that here also just to have you think that, while we talked about 6 components of a reflex arc, we really didn't even include the named peripheral nerve that these neurons are traveling in. So that could actually comprise a 7th component of your standard deep tendon reflex arc. And I'll show you how we elaborate on that when it comes time to report our findings to any third-party payers such as insurance companies, attorneys, judges, claims mediators, or what have you, for those of us that are involved in medical legal work. Okay, so we've done our reflex testing, and we find that reflexes can be graded on a scale of 0 to 4. And according to the AMA guides state that reflexes are going to present in only one of 4 different ways. They can be normal, they can be increased, they can be reduced, or they can be absent. Now, depending upon how the reflexes are, will start to give us our first indication as to what type of condition our patient is presenting with. With radiculopathy, the reflexes are going to be reduced. With myelopathy, the reflexes are going to be increased. Okay, so absent reflexes would be graded as 0. That's known as areflexia. That would be suggestive of radiculopathy. Reduced reflexes would be graded as a grade 1. That's also known as hyporeflexia. That also would suggest radiculopathy, although could be normal for this particular examinee. Reflexes that are normal or average are graded as 2 or 3. And then reflexes that are overly active, also known as hyperreflexia, are graded as 3+ to 4. And that would be suggestive of myelopathy. Now, with increased reflexes, we call that hyperreflexia, grading in the 3 and 4 ranges. Now, there's many possible causes of hyperreflexia. First of all are the physiologic causes, meaning that it's basically considered to be normal for this particular examinee. Some people do have what you would consider to be active or overly active reflexes, but that's just typical for them. And one way to determine that would be to test bilaterally and then also compare upper extremities to lower extremities. And if it's physiologic for them, you're going to find the same degree of reflexibility in all areas that you test. Hyperreflexia could also be pathologic, and there's many different causes, the most common of which that we are going to be dealing with and that we've already alluded to earlier are due to degenerative lesions of the central nervous system, especially with regards to cervical spondylosis. But that's not the only causes. It could be due to malformation in the central nervous system, some vascular or traumatic injury to the central nervous system, And then also certain toxic or metabolic disorders such as hypocalcemia and or tetany can cause hyperreflexia as well. Now the extreme of hyperreflexia is manifest as clonus. Now clonus comes from the Greek word meaning violent or confused motion. And what clonus is clonus is a series of involuntary and rhythmic muscular contractions and relaxation. So there's this sort of rhythmic oscillation between contraction and relaxation. And that cycle, that relaxation contraction cycle, continues rhythmically. And clonus is a sign of certain neurologic conditions, such as myelopathy, and other conditions associated with upper motor neuron lesions that affect descending motor pathways. And in many cases, you're going to see that clonus is accompanied by muscle spasticity, which is just another physical exam finding for hyperexcitability of the muscles. And this is due to upper motor neuron lesion. So clonus causes large motions that are usually initiated by a reflex, and we'll talk about how to initiate the reflex in just a moment. Studies on clonus have shown that the rhythmic oscillations of one cycle range from about 3 to 8 cycles per second, and may last the whole cycle of clonus may last from a few seconds to even several minutes, depending upon the patient's condition. Now, clonus is typically elicited at the ankle, and how you elicit or test for clonus is as follows. You first rapidly flex the foot into dorsiflexion. That would be pushing the toes upward. This induces a stretch on the gastrocnemius muscle, and you could consider this to be the first component of the reflex arc, the stimulus, the rapid stretch of the gastrocnemius muscle. Now, unlike the deep tendon reflexes where the stimulus is brief and momentary, with eliciting clonus, you're going to sustain the pressure on the sole of the foot. And what that does is it reinitiates the stretch once the contraction, the initial contraction, subsides. So let's go over that again. Your job as the doctor is to do two things. Number one is to initiate the stretch, the rapid stretch, and initiate the reflex. And then to sustain that pressure on the sole of the foot such that after the reflexive muscle contraction occurs, your sustained pressure then drives the foot back into dorsiflexion, reinitiating the whole reflex cycle again. And this will cause clonus and will manifest as subsequent beating of the foot. Now, only a sustained clonus of over 5 beats or more is considered abnormal, because less than 5 beats could be considered normal. And you may find that in some of your examinees who are otherwise normal. But over 5 beats or more is considered pathologic. Now, in addition to the ankle, clonus can also be tested at the knee and other areas. And for those of you that have the PowerPoint presentation, you can follow my mouse here, and here's an actual live link to a YouTube video that shows a demonstration of eliciting ankle clonus and the subsequent beating of the foot more than 5 beats, which qualifies as true, bona fide, and pathologic clonus. Okay, now with the cervical spine, the typical reflexes that we test are going to involve the C5 biceps reflex, the C6 brachioradialis reflex, and the C7 triceps reflex. And I want to give you some idea now as to what it means when you have normal active reflexes. As I said earlier, reflex testing is one of our few and only truly objective tests that we have in our doctor's bag. And so imagine you're with an examinee who has all types of reported symptoms consistent with either radiculopathy and or myelopathy. Perhaps imagine that you're in a medical legal setting, perhaps with a workers' compensation case, and your examinee has a history of either radiculopathy or myelopathy symptoms, and they've had treatment for such, and some of their diagnostic imaging studies are consistent with such. And you go through your reflex testing and you find that your biceps reflex is normal, your brachioradialis or extensor digitorum reflexes are normal, your triceps reflexes are normal. What does that mean? Well, I want to give you an idea what that actually indicates. And so let's just consider with regards to the biceps reflex. Now, the same pattern would apply for the brachioradialis reflex and the tricep reflex, but just considering the bicep reflex, normal reflex indicates normal function of at least the following structures. It indicates that the left and right stretch receptors in the bicep muscles, which we call those the muscle spindles, those were the second component of the reflex arc. These specialized stretch receptors are functioning. It indicates that the left and right C5 sensory nerve root function is normal. It indicates that the left and right musculocutaneous nerves, which is the peripheral nerves in which these sensory neurons travel, is functioning normally. The left and right musculocutaneous nerve is functioning normally. And remember that the musculocutaneous nerve is made up of nerve roots from C5, C6, and C7. It indicates at least that the C5 level of the spinal cord function is normal, and that was our fourth component of the reflex arc, spinal cord, where these mono or polysynapses take place. That has to be functioning properly to have a normal and brisk reflex. It indicates that the left and right C5 motor neuron function and motor nerve root function is normal. It indicates that the left and right musculocutaneous motor nerve function is normal. It indicates that the left and right biceps muscle function is normal. And the same findings would apply in the case of normal brachioradialis reflexes and in the case of normal triceps reflexes. And really, it indicates preserved and intact function of cervical spine nerve roots, cervical spine, and upper extremity peripheral nerves. And so really, normal reflexes is indicative of normal neurologic function of both nerve roots and spinal cord. So, despite claims of symptoms that may be sound similar to radiculopathy or may sound similar to myelopathy, in the presence of normal reflexes, you may need to revisit your diagnostic impression. Now, similarly, in the event of bona fide radiculopathy or bona fide myelopathy, we would see alterations in the normal reflex due to damage to one or more of these components of the reflex arc. With myelopathy, we have damage to the spinal cord. With radiculopathy, we have damage to the spinal nerve roots, both of which are going to affect, although in different ways, they're going to affect the subsequent reflex down at the biceps level. Okay, so that is probably a more extensive review on deep tendon reflexes than you needed, but I think it's a good exercise for us to review that, because sometimes we take for granted and we just get routine in these maneuvers that we do, and we don't really think about what it is we're doing and what it actually indicates. And further, we don't probably give enough consideration to associated validity and credibility issues as we're conducting our examination maneuvers. So I think that's a valuable exercise that we went through. Now, in addition to deep tendon reflexes associated with radiculopathy and myelopathy, when we further consider myelopathy, there's some other types of reflexes that we want to consider. And reflexes, as I said earlier, are going to be very important for us in our determination, ultimately to conclude for a diagnosis of myelopathy. First, on the basis of the deep tendon reflexes, we said that with myelopathy, we're going to have hyperreflexia, possibly even clonus. Well, in addition, we're also going to see the presence of what are called pathologic reflexes, and the most commonly tested pathologic reflex is the Babinski reflex, but there are others. There's the Hoffman reflex and there's the Schaefer reflex, and we're going to go into several of the different pathologic reflexes that are positive in cases of bona fide myelopathy. And then in addition to reflex findings for myelopathy, there's going to be a couple of other examination findings that will strongly suggest myelopathy, and that is, number one, the Lair-Mitt sign. We'll go over the Lair-Mitt sign here shortly, and then also the myelopathic gait, and we'll describe the myelopathic gait here also very shortly. Okay, so in order to understand the pathologic reflexes, such as the plantar reflex and the Schaefer reflex and the Hoffman reflex, it's going to be necessary to review some of the anatomy of the upper motor neuron and the cortical spinal tracts. Because with myelopathy, we have an interference to the spinal cord, and that can affect the cortical spinal tracts, the descending motor cortical spinal tracts, and then also can affect the ascending sensory tracts. So let's go through the very briefest of all reviews here of these cortical spinal tracts. And this is not intended to be an exhaustive review in neuroanatomy. Of course, that would be prohibitive here. But I think a brief review will help refresh your memory about some of these structures, and also bring current some of the language associated with the anatomy, really, of myelopathy. So when we're talking about upper motor neuron lesions, recall that the upper motor neurons begin in the primary motor cortex, and that's that area of the cortex located immediately anterior to the central sulcus of the brain. Now, the sensory information, the primary somatosensory cortex, is immediately posterior to the central sulcus. So the sensory and motor areas are in close approximation anatomically. But the primary motor areas are concerned right now, and these upper motor neurons have their nerve cell bodies in this area of the brain. And I'm sure you remember back in your neuroanatomy training, you remember those pictures of the sensory and motor homunculus, or homunculi, I guess is plural for two homunculuses. And so for those of you that have the handout materials in the PowerPoint, I have a diagram here of the sensory and motor homunculi that shows the relative contribution of sensory and motor neurons to the various somatic parts of the body. So these upper motor neurons, they begin in the primary motor cortex, and then from there they descend, and ultimately they synapse in the spinal cord with lower motor neurons that then go out to innervate all the muscles of the body. Now, when these upper motor neurons descend from the brain down into the spinal cord, there's two categories of descending motor tracts. There are the pyramidal tracts and there are the extrapyramidal tracts. Now, the pyramidal tracts are going to include motor neurons from those regions of the primary motor cortex that we just talked about, immediately anterior to the central sulcus. All of those motor neurons descend in what are known as the pyramidal tracts, and they descend down as thick bundles, and they cross over in the medulla at the decussation of the pyramids. And then they continue down in the spinal cord, and there's two tracts. There's the lateral cortical spinal tract, and there's the anterior cortical spinal tract, and these are all upper motor neuron lesions. Well, in addition to these pyramidal tracts, there are also extrapyramidal tracts, which are also upper motor neurons. However, these upper motor neurons of the extrapyramidal tracts do not have their nerve cell body located in the primary motor cortex. They have their nerve cell bodies located in other brain regions. And there's four main ones that we'll talk about here. First is the reticulospinal tract. And for those of you that have the PowerPoint demonstration, I have my mouse pointed over one of the reticulospinal tracts right here. This is the medial reticulospinal tract. And then here is the lateral reticulospinal tract. Now, the reticulospinal tract, these neurons originate in the brainstem reticular formation, which is in the medullary pontine area. Then we have the tectospinal tract. These neurons arise from the dorsal part of the mesencephalon, which is a big word that we use for the midbrain. And this area of the mesencephalon is made up of the superior and inferior colliculi. And I'll tell you the function of this tract here in a minute. Then we have the rubrospinal tract. The rubrospinal tract originates in the rostral midbrain red nucleus, and rubro means red. And then we have the vestibulospinal tract, and these neurons originate in the vestibular nuclei in the pons and medulla, and those nuclei are associated with receiving inputs from cranial nerve number 8, the vestibulocochlear nerve, especially the vestibular portion of the vestibulocochlear nerve. So we have these descending tracts traveling in the spinal cord. Now, the AMA guides talk about the cortical spinal tracts only. They don't talk about the extrapyramidal tracts, but of course, with an injury to the spinal cord, you could have injury to any or all of the pyramidal tracts or the extrapyramidal tracts. Now, the pyramidal tracts, which we said consist of the anterior and lateral cortical spinal tracts, have characteristic symptoms when those tracts are injured or damaged. The anterior cortical spinal tract is involved with motor activity of the upper extremities down to about T6, and it controls the central axial and girdle muscles. The lateral cortical spinal tract is involved with fine movement of the limbs, and we find that injury to the lateral cortical spinal tracts is common in myelopathy, affecting fine motor tasks and fine motor control, particularly of the upper extremities. With the extrapyramidal tracts, we associate the reticulospinal tract with locomotion and postural control of the trunk and proximal limbs. So you can imagine what kind of deficits you could suffer with injury to the reticulospinal tract. The tectospinal tract is involved with coordinating head, neck, and eye movements primarily in response to visual stimuli. So probably not as much involved with cervical myelopathy, since this is involved with muscles of the head and neck region. The rubrospinal tracts are responsible for large muscle movements as well as fine motor control. The rubrospinal tract terminates primarily in the cervical spinal cord. That suggests that it functions probably mostly in the upper limb and is not involved with lower limb activities, but certainly injury to the rubrospinal tract could affect fine motor control of the upper extremities. And then finally, the vestibulospinal tract is involved with changing the position of the body and the limbs to maintain posture of the body in alignment with the head. And so it's the vestibulospinal tracts that we associate with balance. So in thinking about the functions of these different tracts, it's not easy to imagine why a person with myelopathy has problems with fine motor control of the hands and with locomotion and balance and coordination of the lower extremities, because really these tracts have overlapping and complementary functions to each other, and injury to one tract or multiple tracts can quickly and easily disrupt functions to both the upper and the lower extremities. So we have these upper motor neuron lesions in both the pyramidal and extrapyramidal tracts, as well as the spinal cord in general, and this affects not only the descending motor control, but also the ascending sensory information as well. Well, one example of altered motor control after spinal or cortical spinal tract injury manifests itself as what are known as pathologic reflexes. Now, the most famous of the pathologic reflexes is the Babinski reflex, also known as the plantar reflex. Now, the plantar reflex is not a deep tendon or muscle stretch reflex. It's not a deep reflex. It's a skin and muscle reflex, also known as a superficial reflex. And there are other superficial reflexes as well. The corneal reflex is a superficial reflex. The gag reflex is a superficial reflex. The abdominal skin muscle reflexes are superficial reflexes. So there are many superficial reflexes throughout the body. And the Babinski reflex is a superficial reflex as well. But unlike some of the other normal superficial reflexes, the presence of a Babinski reflex is a positive finding for an abnormal condition, meaning it's a positive finding for upper motor neuron lesion or cortical spinal tract lesion or myelopathy lesion or spinal cord injury lesion. So according to de Meyer, the author of the 5th edition of the Technique of the Neurologic Exam, he states that the most important of all reflexes is the plantar reflex. So let's talk about the plantar reflexes and some of these other pathologic reflexes that do manifest themselves in the case of bona fide myelopathy cases. So to elicit the plantar reflex, start with your examinee supine, meaning that they're non-weight bearing. The limbs are completely relaxed. And then you as the examiner then stroke the lateral side of the sole of the foot, moving from the medial calcaneal tubercle to the head of the third metatarsal. Do not stroke the toes, because that elicits an entirely different type of reflex associated with pain or tickle. In fact, tickle is a form of pain. Now, the length, velocity, and pressure of the stroke are important. You don't want the pressure of the stroke to be too deep that it stimulates pain receptors. Again, that would initiate a withdrawal reflex. So you want the pressure to be just enough to elicit a skin reflex, but not a pain withdrawal reflex. Now, in the normal examinee with normal neurologic function, the large toe will plantar flex, and you may have seen this described in some of your medical reports as the toe was downgoing. The large toe was downgoing. Now, with corticospinal tract damage, in other words, in the presence of an upper motor neuron lesion, the large toe extends rather than flexes at the metatarsal phalangeal joint, and this is known as a positive Babinski sign. Now, there is no such thing, by the way, as a negative Babinski sign. If you have a normal response, meaning that the toe plantar flexes, you would just simply state that the toes were downgoing. You only report a Babinski sign when the sign is positive, meaning that the toe extends at the metatarsal phalangeal joint, and you only conclude that Babinski sign is positive when the reflex is repeated or repeatable on multiple occasions. Simply eliciting an extension response one time is not considered a positive Babinski sign. Okay, so how does this reflex work? Well, there are several theories, and I've read 3 textbooks on this and came up with 3 slightly different explanations for the positive reflex, for the plantar reflex. So I conclude that authorities are not unified on their explanation of this. But one explanation for a positive Babinski reflex is as follows. And this is a similar pattern that we're going to see with other positive pathologic reflexes. First of all, you need to consider that the reflexogenous zone for the plantar reflex is the S1 dermatome. And when you stroke the sole of the foot, you need to make sure that you're staying on the lateral aspect of the foot in the S1 dermatome and not migrating over into the L5 dermatome. Now, the afferent nerve is the tibial nerve. Now, the tibial nerve is a peripheral nerve composed of L4, L5, S1, and S2 nerve roots. But this reflex is initiated in the S1 dermatome with S1 sensory neurons. Those neurons travel towards the spinal cord in the tibial nerve. Now, the reflex is mediated by the L4, L5, S1, and S2 levels of the spinal cord, meaning that those S1 sensory neurons enter the spinal cord primarily at the S1 level. However, once in the spinal cord, they can ascend and descend the spinal cord before making their first synapse. And I think it's important right here to perhaps review the anatomy of the lumbar and sacral spinal cord, and that is that the spinal cord ends at spinal level L1 to L2. Now, there's tremendous compaction of the spinal cord and of neurons in the spinal cord in this terminal end of the spinal cord. We call this terminal end of the spinal cord the conus medullaris, the terminal cone. And the conus medullaris is an enlarged portion of the spinal cord. If you look at it in cross section and even in longitudinal section, it's enlarged compared to the thoracic spinal cord. And the reason it's enlarged is because it has to accommodate millions and millions more sensory and motor neurons associated with the pelvic organs and also with the lower extremities. So all these neurons, both sensory and motor, are tremendously compacted into this small area that ends at around the L1 to L2 spinal level. Well, think about it. we got a whole lot of spine left beyond L1 and L2. We have the whole lumbar spinal cord, we have the whole sacral spinal column, and we have the coccyx down there. So there's a lot of spine left after the spinal cord ends. So these neurons from the S1 dermatome from the bottom of the foot come into the S1 through the S1 nerve root. However, they can ascend slightly up in the spinal cord, and I say slightly because it's a very small distance down here. They can extend up to L4. They can extend down to S2. In other words, they spread when they enter the spinal cord. Well, once in the spinal cord, they synapse with motor neurons, and the efferent motor response is mediated back through the L4, L5, S1, and S2 nerve roots to the sciatic nerve to its bifurcation. Now the sciatic nerve bifurcates right behind the knee, where it then continues down as the deep peroneal nerve and the tibial nerve. Now the toe flexors, such as the flexor digitorum and the flexor hallucis longus, those toe flexors are innervated by the tibial nerve, while the toe extensors, such as the extensor hallucis longus and the extensor digitorum longus, those are innervated by the deep peroneal nerve. Different innervations, see? Different peripheral nerve innervations. And normal response is toes down going, toe flexion. Abnormal response is toe extension. So the theory is that loss of the normal descending pyramidal control of the reflex arc to suppress extensor withdrawal results in the upgoing toes, the extension of the first metatarsal phalangeal joint. This is known as the positive Babinski sign. So really, it's the elicitation of an extensor withdrawal response from a stimulus that should otherwise not create an extensor withdrawal response. Do you get that? That's the reason that your stroke can't be sufficient, that it would create pain and thereby cause a normal extensor withdrawal response. So that is the theory. Due to cortical spinal tract injury or upper motor neuron lesion, there's lack of suppression or lack of inhibition of the extensor withdrawal response, and then therefore we get an actual extensor withdrawal response, and that's manifest as the great toe, the big toe, moving away into extension. And we call this a positive Babinski sign. It's positive for upper motor neuron lesion. So the extensor toe response is a sign of some sort of interruption of the pyramidal or extrapyramidal motor pathways. It's significant for an upper motor neuron lesion. Now there's other types of reflexes that we can elicit, and you've heard of some of these, such as the Chattox reflex and the Schaefer reflex and the Gonda reflex, etc. And really, these are all the same pathway. These all involve the same pathway as the Babinski reflex. The only difference between them is that they just involve different stimuli, all still within the same S1 dermatome. However, they all result in a similar extensor response. So with the Chattox reflex, we stroke the lateral malleolus, and we see a extensor toe response. With Schaefer reflex, we squeeze the Achilles tendon and get an extensor toe response. I say we get a response, that is when there's an upper motor neuron lesion, that is. With the Oppenheim reflex, here we apply pressure to the medial side of the tibia, and we get an extensor toe response. The Gordon reflex, we squeeze the calf muscle. The Gonda reflex, we flex and suddenly release the fourth toe. And they're all the same. They just involve different stimuli within the S1 dermatome that initiates this pathologic extensor withdrawal response. Now in the upper extremities we have a pathologic reflex as well that we can test, and this will be positive in the event of a high upper motor neuron lesion, meaning in the cervical spine, that is. Certainly a thoracic spinal lesion is not going to cause a pathologic reflex in the upper extremities, but the Hoffman reflex is one reflex that will be positive in the case of cervical myelopathy. And to elicit the Hoffman reflex, you, the examiner, takes your examinee by the hand, and stabilizing the palm of the hand, you depress the distal phalanx of the middle finger and then allow it to flip up as your flicking pressure moves over the nail bed. Now, as the finger flicks up into extension, the extension of the distal phalanx stretches the flexor muscles, the flexor digitorum profundus muscles, and this causes the fingers and the thumb to reflexively contract, and you'll notice that the index finger and the thumb contract closer to approximate each other. Now, this method is effective only with very brisk reflexes, and so therefore this maneuver is performed when myelopathy is suspected, such as, for example, when your physical exam findings are significant for hyperreflexia, meaning very brisk muscle stretch reflexes. Then you would follow up that finding with a Hoffman's reflex test.
Okay, doctor, so I hope that helps you. That was a thorough and excellent review of reflexes related to radiculopathy and myelopathy. And remember, in a bona fide case of radiculopathy, the examinee is suffering an injury to the spinal nerve root, which transmits lower motor neuron fibers and also sensory fibers. So with a bona fide radiculopathy, an active symptomatic radiculopathy, the examinee will suffer hyporeflexia, a diminution of the reflex response. Whereas with myelopathy, since we're dealing with an upper motor neuron lesion, the examinee will present with hyperreflexia to the same reflex testing at the same locations of testing as for radiculopathy. Okay, such as at the triceps, such as at the extensor digitorum, such as at the bicep tendon. The myelopathic patient will express hyperreflexia with reflex testing. And then in addition, in myelopathy cases, we'll also see the presence of pathologic reflexes, the most common of which are the Hoffman reflex at the fingernail, and also the Babinski reflex with stroking the sole of the foot. So for those of you that are involved in medical legal work, many times you'll have examinees present with what seems to be like radiculopathy type symptoms. In other words, they report pain and paresthesias in the distribution of a spinal nerve root, but the radiculopathy cannot be verified by physical examination. And in medical legal work, this is referred to as non-verifiable radiculopathy. It doesn't mean that the examinee does not have radiculopathy. It just means that the physical examination, such as sensory testing, such as motor testing, such as reflex testing, is all normal. So the examinee's radiculopathy cannot be verified by physical examination. Similarly, they may have electrodiagnostic studies that fail to definitively identify radiculopathy. Well, this is referred to as non-verifiable radiculopathy. So in both non-verifiable radiculopathy cases and even in cases of bona fide active radiculopathy, you may encounter normal reflexes. So in the presence of normal reflex, what does this tell you? This tells you that the examinee has many, many structures functioning normally in order to produce a normal brisk reflex. So for that reason, reflex testing is so valuable because it's one of the truly objective tests that we have. In other words, reflex testing cannot be in any way manipulated by the examinee. So I love it because it's a truly objective test, and in the presence of normal and brisk reflexes, that tells you that despite the examinee's complaints of radiculopathic type of pain, all of the associated structures involved, including the spinal nerve root and including the spinal cord, where these polysynaptic reflexes connections take place, all of those structures are functioning properly. So brisk and normal reflexes are negative findings for both radiculopathy and myelopathy, despite an examinee's reports of symptoms. This is a recurring theme that you may encounter in your medical legal practice, although it's something you'll probably not encounter in your clinical practice. Okay? So in our next session, we're going to start getting into the orthopedic physical examination maneuvers to assess for radiculopathy and myelopathy, and we're going to begin our next session with a discussion of the physical examination of the cervical spine. So this is Dr. Perry Carpenter. I want to thank you for joining me on this week's video. I look forward to being with you on our very next video as well.